All right. Well, welcome to EMS Office Hours. I am Jim Hoffman,
I'm Josh Knapp.
and we're joined today in a little special time of the show with Bram Duffee. Bram, how are you doing?
I'm doing great. Thanks for having me, y'all.
Am I
It's good to
saying your
be.
name right?
Yeah, it's Bram Duffee. That's me.
Okay, perfect, perfect. Well, I wanted to jump on today. Bram, you contact me on LinkedIn about doing a show with me. And I just want to remind you, if you're on LinkedIn or any place for that matter, if you want to come on the show and talk about something that you're passionate about in EMS, or maybe something you've done that other people in EMS might be interested in, be sure to message me. I'm always open to have people come on here and talk about things that they're passionate about. I actually was talking to somebody who I had on the show 2019, and she was a student, and talked about how it was. She was actually re-listening to the episode, and now she's a full paramedic, and she's actually teaching. So she wants to come back on and talk about like that transition between the two. So we'll be having her back on soon. But today, uh, we're here with Bram Duffee, and he's a paramedic, and like he says, a little signature there. He's also a PhD from Houston, Texas, right, Bram?
That's me. Yeah.
All right, great. So the thing that you contacted me about is this book here that's kind of covering half of my image if you're looking at it. Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. And at first I was like, all right, who's going to be whipping out their little timepiece and trying to do Jedi mind tricks on patients in that 10 and 15 minutes that we're with them, on the scene. So, but then I started looking at some of the write-ups for it, some of the press releases for it, and it's a little bit more subtle than that, right?
Well, we talk about all forms of hypnosis to better understand it in the book. But yes, this is definitely something that's very special for paramedics and first responders. And it's all about working to use our words for the better, our words for healing instead of negative. And one of the things that inspired me to write this book was the fact that I've been a paramedic for 25 years, and I have a lot of, I've had a lot of moments in my career where I just like sort of was, uh, what's the word for it when you just have cringe? I have like full cringe because of sometimes the things that we say in front of patients or how we
Yeah.
talk to patients. And the reality is that we, even as responders, are in some pretty incredibly dramatic moments. And so we don't always watch the things that come out of our mouths at the right time.
Oh,
I
yeah.
mean, when we're looking at the most horrible of horror, it's sometimes slips. And so one of the things my book helps us do is sort of refocus our words, think about what we say, and we push forward this theory that is called the fear hypothesis. And my co-author and I really work to focus on that in this book. And basically, it comes down to we believe that an extreme amount of fear that someone can have can put them into a hypnotic state just like that. And so it's sort of
You
like
know about patients or both, patients and responders?
a patient. So you as a patient are having a heart attack, the chest pain started, you're diaphoretic, you're dizzy. That moment is a fear moment where you're highly susceptible, highly vulnerable to being thrusted into a hypnotic trance. And so what that means is that, so if someone gets their arm cut off or is having an asthma attack or, any of these things that we see commonly, they instill a lot of times an intense amount of fear into a person. And so it's sort of like, we like to, my co-author and I like to talk about this in terms of horses. We both have a horse background. He was a horse trainer. I grew up on a farm with horses. And if you spook a horse, they lose their damn mind. They're not even, they're not even with this world. And
Yeah.
it's sort of similar to that. When humans get spooked on that incredible level, it means that it means that we don't have to have a stopwatch. It means that we don't have to do anything special. And what we advocate for in our book is that we think that there's a really special way that you can use your words during this moment, during this hour that they're susceptible to problems, to make things better for them. And so when you say make things better for them, there's a big spectrum there, right? So I want to say that, yes, I think it's possible that you can do physical changes to the body based on hypnosis, but at the far end of the spectrum, but at the small end of the spectrum, at the very least, we know that we can do things like reduce pain and help someone be more relaxed and calm. And so those are very widely used reasons for hypnosis. And it's a field that has a lot of speculation, and that's why I think that it's so good to be able to highlight the fact that we as responders are actually in situations every day where we walk into the fact that this person is already in this trance, and so
Right.
we don't have to do anything extra except now think about that. And so some of the things I think about are just small ones, like the fact that if we know that if you say things to someone who's in a hypnotic trance, that it can stick with them for a lifetime. Like if we have a child that's getting bitten by a dog, then some of the things that are said within that first hour can affect them for their whole life. They may be afraid of dogs, forever. And so just knowing that we want to protect the patient from negative, language is really helpful. And knowing that now we're giving permission, this book does, we're giving permission for first responders to finally be uplifting and positive, because we think that that making positive statements that can help the patient feel better is a good thing. 25 years ago, when I took my first EMT class, I remember that it was probably the first week. They were telling me that, you're not here to go overboard with these reassuring statements. You don't know if the patient's going to live or die. You don't know what's going to happen next. You can't promise the future, so don't try. And I think that some of us have that, have that mindset. And what it prevents us from doing is it prevents us from giving our patients positive hope, like these positive suggestions can really help someone get through these horrible situations. I talk about this because, I think about my own family, and I think about, how I would want them, the first responders to be treating my mother, for example. She was in a car wreck in Atlanta, and I was here in Houston. And as a paramedic who does the job every day, I was just sick about the fact that, I wasn't going to be able to be there for my mom. And I don't know how, rough or how, aggressive those responders are going to be with my mom. And it really made me upset. And so those kinds of things fueled me. It's like, we can say that we treat everybody like family, but do we really, do we have that in our minds the right way? Because I can tell you that it's really difficult for me at 3 o'clock in the morning on a 24-hour shift to be uplifting and positive, but I'm actually the only one there that's in a position to infuse anything positive, because this is a horrible damn situation that we're usually helping someone face. And so this has been a project that I've been working my whole professional life on, and people joke with me that I have a PhD. And this is all about being able to look into these, look at this and analyze and understand the communication elements and the psychology parts of it. And I want to tell you that I started out as a big skeptic, and I'm on the other side of it as an expert now, telling you that this is something we should all look at together.
Yeah,
Hey,
I
Bram.
it's one of the things I know. Like inside my membership site at Therapeutic and stuff, I have a a patient rapport segment in there to try to help people be better with their patients and communicate better, because it is a very big piece of what we do. And I think, like you said, sometimes 3 o'clock in the morning, you're not really at your top of your game to be that uplifting person, to do that. And I think we have to remind ourselves of that. And like you said, interesting to me when you talk about how patients that are in these situations are in that sort of state, that hypnotic state, right?
Yep.
I'm sure a lot of people here remember, like when you talk about people having heart attacks, don't use loud things, sirens, don't do this, don't do that, to try to keep them calm and not
Calm.
trigger them to escalate whatever it is that's going on with them, right? So I think that this, I think, is a maybe bring some clarity to that, to recognize that patients are maybe going through this and we don't even realize it, right?
Yeah.
Hey, Bram, before you answer that, I wanted to just, I have a big question that sort of frames where you're coming from. What is your PhD in?
So my PhD is in human development, and specifically what I studied was paramedic decision making. And so it was not hypnosis related, but
Right.
it was thinking and communication related. So this is a
Communication
segue.
about the job. This is something that we all face. And if we're lucky enough to have had good experiences or good instructors or good partners that can sort of teach us the importance of what the reflective aspect of communication and the importance of what we have to say as providers. It can really make a big difference, because I too sort of went through that EMT level 101 of you're not allowed to don't make promises you can't keep, don't make promises you don't know. But there's a whole big world of difference between having a positive outlook and lying.
Yes.
And that's sort of the angle, that weird, don't make promises training that almost universally EMS gets. And the idea of, build a rapport with your patient. It's the very classic. If you've done any part, and at 25 years, I suspect that you've dabbled in a lot of aspects of this. I've had 20 years. Jim has had since the Stone Age. His protocols were carved on tablets. But the aspect when you're in a rescue situation, sometimes you have to sort of break the panic by saying, look at me, focus on me.
Yeah.
I'm working with you right now. This is, these are the things I'm going to do. And you can sometimes you can gain back that level of communication by just, saying what you're doing. Hey, listen, I'm going to put a little bit of oxygen on you. It's going to allow you to breathe a little bit better. And then I'm going to start an IV. Is that okay? And you can sort of work in the whole schmooze, so to speak, during your patient contact. And I wanted to also remind Jim that you're in Texas. So instead of like a big city, like I'm in New York, Jim comes from New York, where our transport times were 10 minutes, your transport times can be 2 hours.
Oh yeah, for sure.
So,
Yeah.
Bram, what about some of the I guess the methods that you're talking about that we can use, and when should we use them, or why should we use them? And do you have, without having to go
Yeah.
through the entire book and all, do you have just some
Yeah.
quick things just to kind of maybe get people to see the benefit of this?
Yeah. So the first thing I want to mention, but before that, is just sort of how all this comes together. Because one of the frustrations that I had was, uh, early on, I, as a paramedic, was frustrated because sometimes I wasn't able to talk my patients into things that I knew that they needed. So like I was super young back then. So I was like, I used to wear earrings. So I would take my earrings out. I don't have visible tattoos. I keep my hair high and tight. That was all specifically because on the job, I went through times where I had older people that would come at me with these things that would make me reassess how I communicated. Because I have had patients that have died because I was not able to convince them to go to the hospital. I know that for sure. So it's a real big deal to me that people respect what I tell them, because I know what I'm doing and I actually care, right? So this was a big frustration for me, and that's why I studied paramedic communication at the scholarly level when it comes to how to best communicate to convince someone of something and all of those different things. And when I met my co-author, his name's Four Arrows, Don Trent Jacobs, he has 2 doctorates. He has 1 doctorate in psychology and another doctorate in education. He spent his life as a hypnotherapist, and he's also a retired EMT firefighter from California. The thing is that I'll put all this together in a second, but I just have to share that, I was going through all this frustration of like, why am I not able to communicate with my patients? It's like when I ask them a question like, do you have any medical problems? Why can't they just tell me? And I didn't know that they were in a trance, and that's why they can't answer those complicated kind of questions. So when I met Four Arrows, Dr. Jacobs, he was a faculty member in my PhD program. So I met him over 10 years ago. I never took a class from him because he was always very eccentric to me. But I finally spent time with him, and this is my aha moment. Okay. So the aha moment for me was that when I talked to him about his experience and how he kind of pulled this theory together, and he was basically telling me that he was a hypnotherapist, like a professional hypnotherapist with a doctorate and everything, who spent a lot of time doing that, who then, as an EMT started seeing patients. So if you're so I asked him, I said, so as a hypnotherapist, that means like you're putting people into a trance. But when you met these patients as EMTs, did you automatically identify that they were in the same trance, that it took you for a long time to put someone in? And he said, yes. And I was like, I'll be damned. I've been trying to figure this out. And it really pushed it. It really convinced me, because, you have someone who's a world-renowned hypnotherapist who, gets his EMT and starts interacting with people. And he's like, look, this is it. They're already in this trance. So I just thought that it was really exciting, sort of like how all this came together, and how this was a big aha moment for him, and a sort of aha moment for me, because not all of our patients are going to be in a hypnotic trance necessarily, but I think that it's safe to say that it's a good idea to talk to everyone like they are, especially when they're going through something severe, because we don't know what their norm is. These are people that we're not with every day. And so I know that you asked about some of the how-tos, or the nuts and bolts of what we talk about in our book, and we go through this acronym for the word credible, 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 and for each letter of the word is a different step to take in our process. And I'll tell you, one of the biggest steps to take in the process is being able to work as a responder to gain confidence and enough to approach the patient the right way, to do the introduction the right way, to build rapport the right way. Right now, I have an article that I wrote for JEMS, Journal of Emergency Medical Services. They have it out for a peer review. But in that article, I wrote a whole article just about the importance and some of the ways that we have to rethink how we build rapport with people. Because just those first few moments, that first interaction is super important, because that's sort of what is setting the tone for the time with you and your patient. And I don't know about you, but I judge people really quickly. And so if I have some weirdo coming up to me, it's going to be my rescue team, I'm ready to ask for a veto, so it's sort of like, we want to establish that confidence right away. And I think that I went to, I used to work for an agency that was really militaristic, sort of, and sort of that's just how they managed people, and sort of even their precepting was sort of done that way. And I remember I didn't work for this agency but about 6 months, because I was not in agreement with their culture. But what happened was that they would talk about patients as if they were not there, like if they were behind some glass. Like they might say, well, you'll notice that this Hispanic overweight female is in the demographic that would normally be someone that would have heart disease anyway. They would just say these kinds of things in front of people. But the thing that bothered me the most was that I was already an experienced paramedic, but I was being precepted to work for their agency, and they made fun of me. It was a nurse and a paramedic that they actually made fun of me after the call because of the way I introduced myself, and it angered me. It made me really mad, because what they expected was basically a full interrogation of the patient, and I'm here to do that, but there's a way to do it so that you can get the most out of it, is what I believe. And so most all of my patients are going to get a full introduction. Sometimes I'll even introduce myself to an unconscious patient because I don't really know if they're unconscious or not. Also, there's family members, bystanders. Like it's nice to have an announcement to the room that the person has arrived to fix the problem,
Yeah.
So these things are not talked about as with a high level of importance, and my book does that. And I think that thinking about how our words heal, it really matters. So it starts out with just the fact of how we put ourselves into the room and how we communicate with those people there. And then knowing that, okay, I'm looking at this patient, they're in a trance. And what's funny, I hope that the viewers think about it like this, just like y'all, now that you can see this theory, I think that it might open your eyes to some of the patients that you've had in the past. Or, when you see your next emergency patient, you might realize that, my gosh, they are not, acting like they're, what a normal person would act like normally, because they have a delayed response. Maybe their mouth is a little bit open, their eyes are a little bit wider. Maybe they have, an inability to answer complicated questions. These things are all normal, and so to know that, I am able to. My goal is to make them feel comfortable with me, because they have called out for help, and I'm the person that's there to help them. And I do need a lot of information. So the way I can best get that information is by building the rapport and making them feel comfortable so that they can sort of give it to me. And then when I ask questions, instead of saying, do you have any medical problems? Instead of that, what I do now is I go through a list. I say, I'm going to ask you some questions, just yes or no. Any heart problems? Any lung problems? Any seizures? Are you diabetic? That's no problem. That's easy. We can move through that list really fast, but asking a complicated question is not it. And so we can take a patient that is lost in the world, that needs help, and let them know that, hey, I'm the dude. I'm your guy now. Okay, you and I are going to get through this together. And one of the things that really was nice to push this forward happened with a physician named Eric Wright back in Kansas in 1976. So it's like 2 years before I was even born. They were already doing research back then on this topic. And what Dr. Wright did was, and I wrote about this in my book, but what Dr. Wright did was he had a control group and then an ambulance group, two different ambulance groups that would respond to patients and interact with them differently. And one did things as normal, and the other group just made 3 simple changes to how they interacted with the patient and what was going on, and they found some really dramatic, awesome results. And so I'll just tell you about those changes and those suggestions. So what we do is we make sure that there's no kind of is that an emergency? No, but we make sure that there's no kind of change to the normal expectation for what we do as medical providers. So we're not saying that ACLS is different, that CPR is different, that anything with how we normally treat people is different. We just want to think about how to talk to them differently. So the first thing is that we protect how they're communicated with. So external messy negativity needs to stop. And we work to do that by insulating them. And if your crew knows that that's the goal too, your crew members that are with you can also help in that regard all the time. The other thing that we do, we've already mentioned, is we build rapport. So we allow that patient to regain some control, to get confidence in you as the provider, and that credibility is able to happen. And then after those things, then you're positioned then to be able to talk to the patient in a way so that they can believe you, so that they can, take in information. One of the things that we that I like to talk about is kids, because if I walk into the room and I have a child with a broken arm, and that parent and the people around them have said things to them like, "Oh, it's just a broken arm. It's going to be fixed. It's not that bad. You're going to be okay," and they give those kinds of words to them, that child doesn't have much trust, because what they're experiencing does not line up with what they're feeling.
Yeah.
And so if I, as a provider, am the first person that walks in the room and says, "Oh my gosh, that looks like that you're in so uncomfortable. I bet it feels awful." And that alone allows that child to go, "Oh, wait, somebody is listening to me here," and it falls in line with what I believe, because it actually does hurt. And it actually, so that's an immediate trust, and then, like with children, especially, I like to touch them at the furthest away. So I usually grab kids by their feet. Like I might grab one of the ends of their shoe while I'm talking to them. These little things can slowly help, the patient become more and more comfortable with you. And it's not like it matters like for any medical reason, except that, you want to start to do things to build that rapport. And then the next thing is to deliver positive, uplifting, healing type messages. And so Dr. Wright, when he did the Kansas experiment, what he did was he had in addition to training the providers on how to just use positive language, they also had, I don't know for sure, but I think it was like a card that they had them read off of. So every patient, after they got, their after they got to a point where they had time to do it, every patient got this read to them. And I could pull it up from my book, but the card would read something like this: "The worst is over now. Everything is going to be okay. I'm here with you to help you through this. I know that you have all this discomfort. We're doing stuff to make it better. We already know the hospital is prepared for you and awaiting your arrival. We'll be talking to them. And so the worst of this is over, and you're going to do great from here on out." So what you noticed there was that I just gave as much comfort as I could. So I am an authority figure, and sometimes I wear a badge, right? As paramedics sometimes do. And if you're in a position where you are vulnerable and you need help, the person that's delivering that help to you, giving you that message, telling you that everything's going to be okay, really can make a big, big difference in how that person feels. And also, one of our goals is to sort of put their mind and body in line for the same goal. Like, there's so much of what we do that fights what our body, needs versus what our brain wants. And I think that, being able to communicate to them that we're here to help you and these are our goals together, kind of helps them forget about some of the things that don't matter as much. And so the other thing just to mention is that we don't like to use the word pain. I think that using that word at all can just add so much negativity that we like to, if the patient wants to use that word, that's fine. But, saying words like discomfort or not good, or, other things are better sometimes, because if you go to a patient and let's say you are the third provider that ends up interacting with that patient, and you're the third person that asks them if they're hurting or if they, have pain. Gosh, about the third time I get asked, if I'm feeling something, I'm going to be like, yeah, maybe I could use some pain medicine. You know what I mean? Like, so we don't need to be in a position to convince our patients that they need stuff. But
I thought the EMT in the back of the ambulance talking to the patient with the chest pain as you're driving
I know,
right to the hospital. You're in the back. You sure you don't have chest pain? Are you
right?
sure?
Right. So there can be some of that. But what I want to focus on are those patients that are in a lot of pain that I can't help. And I think that matters a lot when it comes to this form of hypnosis, because I've had patients that were in severe pain and I could not get an IV for whatever reason, or their blood pressure was too low, or there was some reason I could not deliver the pain medicine. Well, this book brings them some comfort, because we talk about trying to make them feel better through using uplifting words that are really akin to what a lot of hypnotherapists use. And so the hypnotherapists, when they have a person in a trance and the trust is established, then they talk to them about then they would talk to them about this in a form of like positive mental imagery. So one of the places that hypnosis is most commonly used that I know about is in burn centers. A lot of times burn centers will have and use hypnosis for patients to get through the pain involved with the recovery. And so during those painful procedures, they will induce them into the hypnotic trance, and then talk to them about imagining the things that would intrigue their imagination to sort of be in another land, to think about other things. And there's lots of distracting ways, and then there's lots of direct ways. Like if you have a patient in heat exhaustion, then you could talk to them about the fan in the room. And it doesn't even take that much, but knowing that there are positive things out there that can help the situation, it's better than just sitting there watching your patient in pain making noise.
Right. Especially like you said, if you can't get IV access and the blood pressure is low and you can't administer that relief. I'll tell you the two things I just wanted to mention. I like the thing you talked about as far as, instead of asking them, do you have any medical history, kind of going down the list of cardiac, respiratory, epilepsy, all that type of stuff, diabetes, to kind of really pinpoint that. Because I think when you talk about the patient being in that hypnotic state, by asking direct questions, you can kind of get them out of it a little bit, right? Get them to get that trust, like you're talking about, pulling them out of that state. Because like what you described too, about the mouth being open a little bit, their eyes being wide, slow to response, that's really sort of the thing that you give the person was in a state of shock, right? Not shock like we know as EMS providers, the low blood pressure, tachycardia, all that stuff. We're talking about in a state of shock, like
psychological shock,
right? The psychological end of it, where they're not responding appropriately. They have their eyes wide open, but it's really more. It's I guess like you're talking about, they're sort of in that state, that hypnotic state where they're not really able to respond.
Well,
by asking questions like you're talking about, being very specific, can get them back into it and get them participating in what needs to happen for their care.
Because it's about participating to help them, right? Because I don't think, based on what I've seen, I don't think that there's a lot that's going to snap them out of this hypnotic trance. I think it just takes time. And so after some time, someone's able to sort of recollect themselves. But during that first hour or so, it's it's like very vulnerable. And I think that we have to just be careful of how we talk to people. And my book actually does not mention the interview method I suggested about just one question at a time for that. But what we do talk about is understanding that they're in a trance. And so, I don't know about y'all, but I sometimes have thought to myself, oh, that was a really frustrating interview, or they seem so stupid. How come they can't just answer this easy question? Yeah. So now that I know this, I have a new thought about it. I'm like, okay, maybe I could, approach it differently.
Bram, you're sort of taking, again, a foundation of how we were taught to interact with the patient and turning it on its ear. I mean, the very standard technique is let's, ask open-ended questions, right? You don't want to ask a closed-ended question, is what they tell you, because you're just going to get a single answer. You're going to get, a small sliver of what you are looking for. And you're saying, in this case, we're looking for some specific information. And when they're in a trance state, or they're in this psychological sort of, they're in pain, or they're in another problem. So they're shutting down the influences from the outside world. And that puts you in that what you're describing as a trance state. So you're not really able to give things the consideration, the thought, the history that you as a patient may be capable of under other circumstances, but under these, you're a little panicked. You're wondering what's going on. There are a lot of new experiences hitting you all at once.
Well, Josh, how many times
so
do you have the patient? I'm sure everyone's done this, where you ask the patient for medical history and whatever, and then you get to the hospital and their history somehow is suddenly different, right?
Right.
Because, like you said, they have so much stuff getting thrown at them that maybe they didn't think of something being a history. But like Bram is saying, if you're being specific on very specific things,
it makes the communication
you kind of
much
avoid
easier.
That surprise.
Sure.
You know what I mean?
So
there's a logic with that.
If I walk into a scene and I don't know what's going on, I of course have to ask open-ended questions. But usually nowadays we know what's going on because we have the computer next to us, or the tablet, or whatever we carry. A lot of times we'll have the communication from the 911 dispatcher, so we'll know we're responding to a child. It's a snake bite. We'll know it's a elderly woman that can't breathe. So it's like, I do ask open-ended questions, but when I do that, a lot of times I'll notice that I have other people responding. I'll ask the patient a question, but then other people respond, and sometimes that's because the patient's not able to really, communicate as well as everybody else, because they're the only one in the room that's in the trance.
Well, keep in mind, everybody else in that room is also going under this assault of the senses.
Yeah,
and that's where you have
especially with the traumatic thing, the bone is sticking out of somebody's arm, or
just grandma is sick.
Grandma, I have literally a ghost, and
and you don't know whether or not the nephew has been drinking all day. Mm-hmm. So there is just the equation gets so many variables at that time that, as a provider, situational awareness is absolutely a component of what we do, what we have to do. But now we're talking about, let's focus our vision down and focus on our patient. What are they going through? What's happening? How do we read and interpret what's happening? And I think that, Bram, your discussion and writing a book on this to say, hey, my observations say that there's something else going on. It's not just a panic situation. It's not just a pain situation. It's not just a communication situation. It's a state of mind. It's the ability for the provider to recognize a state of mind that the patient is going under, so you can modify your interaction with the patient, making it more effective, getting more out of it, helping your patient more, which is a golden thing. I mean, we're all looking for that.
Exactly. And, this is also, it's not a new idea in the literature. It's just that I'm sort of the first person to bring it to the EMS world directly, because, my goal is to think about the possibility of making changes in our paramedic curriculum. So one of the parts in the curriculum is called preparatory, where we talk about that interpersonal communication aspect. This is where that belongs. And so my background is interesting because I actually am a speech teacher. So I teach public speaking at the college, right? And I'm also a paramedic. So I'm like one of these folks who always am in a profession where I think about how people communicate, and I critique myself and how I communicate and how students communicate. So like I am sort of in this weird spot where I've been able to analyze this communication. And then my co-author has been in the spot of, the professional hypnotherapist. And the book that I want to mention, if other than my own book, if anyone's interested, there's a book that's called The Worst Is Over by Judith Acosta and Judith Prager. And they talk about some of the same exact elements of the trance and how this happens. And they also talk about Dr. Wright and his Kansas experiment as being, one of the things that really pushed this initially. So if anyone's interested, check out Judith Acosta and Judith Prager's book. But if you're somebody who's like not even remotely interested in connecting hypnosis with medicine, but just thinks that this is a really cool topic, there's a professional hypnotherapist from the UK named James Tripp. And the reason I like his last name's with it has two P's on the end. So it's James Tripp. The reason I like him so much is because he wrote this book that's called Hypnosis Without Trance. And what he talks about is how to take people that you're having regular conversations with and use the regular conversation to move them towards being in a trance. So it's really cool stuff. So this guy also does stage hypnosis and all of this kind of, this showboating and whatnot. But it reminded me so much of what I do as a paramedic, because I am having conversations with people who are in a trance, and so he talks about that directly. And I've never met, any of these people, but I've read a lot on the topic, and I just think that there's all different kinds of angles that come together to make this hypnosis thing work. And there's two things I want to mention. One is that this hypnosis stuff is actually real. So if real means that you need to see something physical, one of the things that they've done since, they used to do different kinds of brain scans, but that were less reliable. But now, over the last 20 years, we have PET scans, PET scans. And a PET scan is usually a scan that's used to look for cancer in the body and stuff like that. And when they do, I talked about in my book studies that they've done PET scans on people in hypnosis and out of hypnosis, and they definitely show the brain uses glucose in a certain area of the brain during a state of hypnosis. And so the proof is there in that we can see the scan that shows, hey, they're in the hypnosis state. And those of course were done by people who had to go through a full induction, where
Right.
they got talked into the trance. And that's totally different than what we get. We get them and they're already there. But the second thing I want to mention about hypnosis is that there's not the whole idea that we're manipulating someone. There is a level that you could push to say that we're manipulating folks. But really what hypnosis is it's a partnership. And that's why I mentioned earlier the article that I'm writing on rapport and why that's so important as a connection to this. Because if you don't believe that person can help you, then the hypnosis, none of that's going to work. It requires the other person to trust you, believe in you, and agree to allow their mind to be focused on a particular thing in the particular way that you're suggesting. So we're not manipulating folks in the full scale kind of horror way. We're partnering with folks, and I think that to understand how we can better partner with people now that we know that they're stuck in this trance is just pretty awesome.
Bram, I have one last question. I know that we're under a time limitation, and I'm sure Jim has follow-ups. But basically, to boil this down, we're talking about communication, effective patient communication, using the patient's state, recognizing the patient's state to amplify the effectiveness of our communication, and some techniques to do that. And it's sort of, it does, there are some things you're taking traditional ideas and flipping them on their ear, which is good. I mean, EMS, like they say about the fire department, 200 years of tradition unimpeded by progress. So EMS carries some of that along the way, and it can be frustrating. I mean, one of the greatest things in current times is the expulsion of the longboard. Just saying, hey, what are we doing? We're hurting people, recognizing that and going along that line.
That's right.
Along that line is this aspect of, always be truthful to the patient, and, how do we deliver that message? And one thing sticks in my craw and has for years. And I'm not sure, I'm looking at your face for this, if you smile or not. Do you recall a TED Talk done by a Long Island EMT? He basically said it was about the idea of telling a patient they were going to die.
No, I haven't.
And he had it. Jim, you remember this guy? Yes?
He said yeah. He's on mute, but he said yes.
He's on mute. He said yes. Yeah.
I remember now.
But he's
off.
an EMT. Is an EMT, and he had to stress the idea that he was an EMT-CC, which is, I have issues about that. That could be an entire another show for Jim and I to just go through. But he sat there and he said, this whole idea that, you're not supposed to tell a patient they're going to die. If you're obviously going to see them and you're looking at them and your clinical experience says they're going to die, it's okay to tell them. And I wanted to get your reaction. Unfortunately, you haven't seen the entire TED Talk, so you can't react to that. But, there is an aspect of that truth, that too much truth, especially when it's speculative truth, is harmful. And I wanted to sort of get input on that.
Well, my first concern is just setting up a self-fulfilling prophecy, because I have been with lots of people as they have died, and I know that there's a lot of things that can play into those final moments. And I think that how we talk to patients just needs to be on the situation. So if I have a hospice patient, then I didn't mention this, but I have some experience as a chaplain also. If it's a hospice patient who's close to death, then there are ways that you can give calm, reassuring messages about death. And if I'm in a position where they're a full code patient and they are on the verge of dying, then I will very much communicate that to the patient, that I am there to make sure that they don't die, that they make it through this, and I'm here to help them. So basically, until something different happens, I stay on the line of, I'm here to help you. We're going to get you. And if they say, I'm passing, I might die right now, then and I'm going to just say, yeah, if you do, that's why I'm here. I'm here to fix that. That's right. Don't do that.
Right. I'm working with you here. You work with me.
Right.
Focus.
Yes.
Yes.
Yeah. And it can be maybe that could give them an extra 5 minutes so that I could get them to the doctor that can do the intervention I can't do. I don't know.
Right.
But I think that everybody talks about how some of this is up to God and some of this is up to me. And yeah, we're talking on the line there, like what's what. But what I do is I go based on, is this a full code patient or not? And then secondly, I talk to everybody just like I would talk to my own mother. And that's it. If she needs to hear the hard words of, come on, we're going to get strong and we're going to stand up together, we're going to, whatever it needs, I'll talk like that. But that's sort of my barometer about how I talk to people and push for encouragement.
All right, guys. Well, listen. I mean, we could talk about this forever. It's a very interesting topic, and I think we come at it with different angles, and I think I'm hoping kind of open people's eyes to some of the things that you've talked about, Bram, in this episode. So, if you're coming in midway on the show live, whether you're on YouTube or Facebook, go back and watch the whole thing, or you can, of course, go to emsofficehours.com and get just the audio version there if you want as well. So I want to wrap it up. But
before you do, can I just mention that if folks want to find me, if they want to find me, connect with me, or participate in my research, or find my book, all that stuff's at my website, professorbram.com. So it's professorbram.com. I also have my own podcast where I talk about EMS research, which is EMS Research with Professor Bram. All that's at the website, professorbram.com.
And I'll put whatever links to that in the show notes, Bram, as well, along with any of the social media stuff too. So anybody wants to follow you or connect with you there, they can do that as well.
And I always get that. I love it. So that'd be great.
How did you find out about our show? about this podcast.
Google's wonderful, and it was also, I think that I initially found you through Google, but then also I started adding myself to like some podcast website that was through Facebook, and I think maybe I saw a mention, but I was really happy to be able to connect. And you and your audience, these are topics that are super connected. So I'm happy to make all this work.
Oh,
I
yeah.
hope that you go back and see a couple of older shows and some of the stuff that we've worked on. We're very proud of the fact that we don't take a typical approach to the EMS world. And it's not, it's a show where you learn, but not where we necessarily teach you something.
Zach, I don't know what the hell I'm doing. I'm winging it.
Yeah.
All right, guys. That's it. As always, I am Jim Hoffman.
Josh Knapp.
Stay safe, everybody.